Hi, this is Brian Kim. I'm going to share with you this patient, and I was following her for a glaucoma, actually unilateral glaucoma in this eye. And as I was following her and doing the requisite glaucoma testing, I also noticed that she had some transillumination defects, as you see here. And as you know, transillumination defects, as you see in this particular picture, the transillumination defects are actually in the shape of the single piece acrylic lens. So this patient has a single piece acrylic lens. I believe that's in the ciliary sulcus and causing UGG syndrome. So I'm going to go ahead and take this lens out, but you're going to have to ask yourself, why did this surgeon put this single piece acrylic lens in the ciliary sulcus? And so you will discover with me why this lens was placed in the ciliary sulcus. And then now my decision after I remove this lens, where am I going to put the new lens? Am I going to try to put it in the capsular bag? Am I going to try to put it in the sulcus? Which lens type am I going to put for each of these decisions? Am I going to do a scleral fixated lens? Am I going to do a suture fixated lens? All of these decisions I have to think very quickly with this patient on the table. And I have a variety of options in front of me because I know how to do these techniques, and so I can quickly pivot and make a decision based upon the situation in front of me. And so that is really the point of this video, because unfortunately sometimes until you get in the eye you have no idea what you're dealing with, but once you get in the eye you can pause and then hopefully quickly pivot and make a decision which you feel is the best for the patient. So I go ahead and make my incision first on the right side and then the left side. This is some intracameral epinephrine. You can tell that the lens is a little bit decentered here. This is some dispersive viscoelastic. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. And this is a 3mm blade, and I like to use this larger incision when I do my exchanges. So I use a Maltman and I'm checking, retracting the pupil just to get a better sense of what I'm dealing with. So it's really hard to tell, but clearly this lens is in the sulcus. I'm able to easily lift it up, so it's clearly not retained within the capsular bag. I'm able to pop that haptic very easily into the anterior chamber, again confirming that the haptic was in the sulcus. And then now I'm ready for the explantation. Again, with these gummy lenses, they're rather easy to explant. Before I cut the lens, I get underneath the lens with the viscoelastic cannula, and I push some more viscoelastic to push the posterior capsule back. So again, this patient has not had a YAG capsulotomy, and the posterior capsule is actually intact. And so again, it goes back to what I'm saying. Why did the surgeon put this lens in the ciliary sulcus when the posterior capsule is intact? It's very odd. So I go ahead and hold the lens with the IOL holders and then cut the lens with the scissors, being mindful, turning the teeth sideways and making sure I don't cut the posterior capsule as I cut the lens in half. Very carefully cutting the lens, being mindful of the position of my scissors, making sure I'm away from the capsule. Like I said, I pushed viscoelastic underneath the lens to push the posterior capsule back. I'm also protecting the cornea and being mindful of the cornea as I'm cutting the lens. So now I have two pieces. Push some more viscoelastic into the anterior chamber. Very carefully take each piece out. I like to go after the right side piece because the right side piece, as you can see, as I pull the cut edge, it will cause the haptic to collapse on itself. So with the two-handed technique, push that left side piece away, grab the cut corner, and as I pull it out of the wound, the lens and the haptic will collapse. I'm using the left side forceps to shield the corneal endothelium as the lens collapses through the incision. And then I grab that other cut edge and I'm able to, again, do the same technique. As I pull the lens out, I make sure that the haptic doesn't roll up towards the corneal endothelium, shielding the corneal endothelium with the left side forceps. Push some more cohesive viscoelastic, and I'm just going to assess what's going on with the bag. So again, why was this lens, the single piece acrylic lens, placed in the sulcus when the posterior capsule is intact? So again, so far the posterior capsule is intact. I'm retracting. It's not completely obvious of where the tear is until I retract the pupil right about there. You can see that there is a anterior capsule tear in that area. Anterior capsule tear, however, there's no propagation of the tear towards the posterior capsule. So I go ahead and make some extra incisions here, and I'm doing that for my iris hooks. I want to really make sure that this bag is really healthy, and I'm considering placing a lens into the capsular bag if I can. And of course, I'm going to do that. I'm going to place a single piece of acrylic lens within the bag. So go ahead and place each iris hook. And when you do a lot of these techniques, the iris hooks really are not that tedious to put in and out. And these are a single-use type hooks. They're rather delicate, and so you can't really be too rough with them. But because they are single-use, once I'm done with them, I can just kind of pull them out very easily. I don't have to worry about trying to preserve the hook. And so it'll be rather quick to take them out at the end. So again, I'm placing these iris hooks with a two-handed technique, and just kind of rotate your wrist so that the hook points down, and then you can catch the edge and then hook it and then cinch down the stopper. Once the pupil is dilated sufficiently so I can see the entire anterior and posterior capsule, I can see that I have adequate rhexis, essentially 300 degrees, except for that one segment, about 1 to 2 clock hours, where I have that anterior capsule tear. But I don't have posterior capsule radialization. It's very important not to overfill the bag with viscoelastic when I do this. You can see here I'm creating another stab because I felt like that iris hook wasn't providing the correct retraction. I want it to be closer to where that anterior capsule tear is, so I repositioned that hook. And as I'm going around, I'm pushing cohesive viscoelastic and trying to visco-separate the anterior and posterior capsules all the way hopefully towards the capsule fornix. Again, all around except for where the anterior capsule tear is. And so you can see I'm spending a lot of time very carefully trying to separate the anterior posterior capsules so I can get this lens, a single piece of acrylic lens, within the bag. So again, if you look real closely, this is what the anterior capsule looks like. Essentially, it looks like a keyhole. So this is the single piece of acrylic lens. Go ahead and place it through the incision, pushing some more cohesive viscoelastic to fill the bag, placing the lens within the capsular bag. And what I love about the single piece acrylic lens, especially the Alcon lens, it's very sticky. And because of that, one, it opens up very slowly so that you have time to position the haptics the way you want to, but also these haptics are extremely sticky. Because of the lens design and material, these lenses, especially the ones in a toric form, they don't tend to rotate, and that's why it's such a stable toric platform. But for the same reasons, for this type of situation where I have good anterior capsule and posterior capsule, but I have a localized anterior capsule tear, I can position the haptics perpendicular to that tear, and I should be in good shape. And so I was able to tuck the haptics accordingly and basically position the haptics away from the tear. I switched to INA. I'm starting to remove the viscoelastic from the anterior chamber, and I'm feeling pretty good about myself. I put the IOP to low. You see, it's only on 20. It's normally like around 50 or 60. And so I thought I was being smart by reducing the infusion pressure and thereby helping to keep a stable situation. But then I noticed something. Something doesn't seem right. And what I noticed right here is there's a localized posterior capsule hole. And I'm not sure how and why that happened. I'm not sure if that's an extension of the anterior capsule tear that was there, but it's round. It's not like a radial tear. So I feel like, okay, can I salvage the situation? I'm not quite sure. I push some viscoelastic into that hole, some dispersive viscoelastic into that hole to plug it up. And then I'm trying to see if I can remove some more viscoelastic. But you can see now the vitreous is coming forward, probably because of the infusion pressure. And now I have a tilted lens and I have vitreous coming up into the anterior chamber. And so that's why this lens is now shifted to the side. I have a big round ovalish posterior capsule defect and vitreous coming forward. And so what am I going to do now? It's okay. The only reason it's shifted like that is because of the posterior capsule defect and because I have no other place for all that fluid to go. So I go ahead and hydrate the incisions, make the eye nice and firm. And now, what am I going to do? If you have that much volume and you have vitreous coming forward, you have to perform vitrectomy. But you want to perform it pars plana. So I go ahead and indent and make a mark 4 millimeters posterior to the limbus with the trocar. And then I tunnel towards that trocar about 3 millimeters and then I dive down. But as I dove down, you saw that the main incision burped and there's a little bit of vitreous coming to the wound. Some of it's viscoelastic. Go ahead and quickly try to do some vitrectomy through the pars plana. And what's neat is as I do this, I immediately see the chamber deepening because while I was doing all those maneuvers with the IA, I could see that the lens was coming anteriorly as well as the lens decentering. So those are the two things. That's when you know you really need to do something. That the lens IOL is actually shifting anteriorly and was decentering away from that defect. And that's because of that volume coming through. So I went ahead and placed the pars plana trocar. And as I did the vitrectomy through the trocar, immediately the lens deepened in position and it started to center even better. And as you see, I'm going to do some more vitrectomy here. And as you do that, you're going to see the lens actually centers even better as I go. So again, great retraction, great visualization because I use the iris hooks to help me see what's going on. Again, I had an anterior capsule tear, placed a new lens into the capsular bag, a single piece acrylic lens, positioning the haptics away. But again, while I was doing IA, that infusion pressure must have caused that capsule to split. And then because of that high pressure and volume, caused the vitreous to come forward, lens position shallowed, and it tilted, shifted over. And so because of that, I had to go in through the pars plana, remove that volume, the vitreous and just the volume there. And by doing it that way, it immediately alleviated the situation. The lens is better centered now. The lens is deep at the sub-iris plane, and everything's looking great so far. The haptics are oriented perfectly. Again, the anterior capsule tear is still localized. It didn't separate or spread any further. And again, this is how I decided to deal with this case. You could have done a variety of different choices, but when I was able to open up the bag pretty easily, and despite the fact that this lens was in the ciliary sulcus, again, I was rather surprised, but the key was the posterior capsule was totally intact and there was a localized anterior capsule tear. Just very carefully and methodically just visco separating the anterior and posterior capsules into the capsule fornix. But again, because of that infusion pressure, it does cause that volume to cause the vitreous to come forward. Because of that infusion pressure, and there must have been, again, some posterior capsule defect at some point, it caused that split. And then I was able to go in to the pars plana, remove that volume, remove the vitreous. Again, I placed the iris hooks for excellent visualization, and really very important to be able to see exactly what's going on. I would have had no idea the actual condition of the capsular bag, the anterior capsule, posterior capsule, without retracting the iris. You can see I went ahead and placed a 10-0 nylon suture because in these situations, the last thing I want to see is vitreous to the wound. This lens is well centered now. Go ahead and hydrate all of the incisions. And again, the single piece acrylic lens within the bag, whenever you can preserve the bag, is really the best position for the lens, not scleral fixating, not eating the bag and abandoning it. You really want to keep the bag whenever you can, especially since there's really good zonules. There's really no zonular issue here. There was just a focal anterior capsule tear with an intact posterior capsule. It really makes no sense to remove that zonular and capsular bag complex. And I was able to open up the bag, deposit the lens in. Because it unfolds very slowly, I was able to tuck each haptic perpendicular to the tear. And despite that hole that was in the posterior capsule, this is what the patient looked like afterward. Again, you can see the transillumination defects on the left side, but otherwise, this patient has a perfectly clear cornea post-op day 1. The pupil is dilated. We put some atropine at the end of the case because I always want to see how it looks. This patient at post-op day 1 had 20/30 vision. Again, I put a little bit of a tight suture when I did it. This is what she looked like at her 2-week visit. I took the suture out and her vision improved to about 20/25 uncorrected, and she was very happy with her result. So I hope this was helpful to you, and I thank you for your attention.